Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey, Insights That Matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lily Shockney.
Hi, this is Lily Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Insights That Matter. Today we are joined by Dr. Justin McArthur, Professor and Director of the Johns Hopkins Department of Neurology, who is here to discuss new discoveries about the brain, including stem cell use, migraines, and movement disorders. I've had the great pleasure of knowing Justin for over 36 years here, so welcome. Glad to have you here today.
Thank you.
Let's first talk a little bit about the number of people diagnosed with brain disorders, because I know that it's increasing. And let's start first with Alzheimer's.
We're really facing an epidemic of Alzheimer's, and not just Alzheimer's disease, but other types of dementia that may be similar to but caused by different mechanisms. And if you look at the statistics, we know that Alzheimer's is very heavily driven by aging. And so, fortunately or unfortunately, America is getting older as a population. And so the incidence, the occurrence of Alzheimer's disease and other related dementias is going up very dramatically. So if you think about where we are now, there's approximately 6 million Americans who have been diagnosed with Alzheimer's disease. And over the next 15 years, we're going to see that number triple. Ooh. So we'll be over 15 million people with Alzheimer's disease, and that doesn't take into account other types of dementia.
That's incredible because, baby boomers are now in midlife, and we are able to live longer, far longer than our grandparents and great-grandparents did. Just hearing the word Alzheimer's usually makes people tremble. I think that they're more frightened of that than they would be even of a diagnosis of cancer today. How about Parkinson's disease? What is the incidence for that?
There's about 1 million Americans with Parkinson's disease, and our understanding of Parkinson's has changed quite a bit in the last 15 to 20 years. First, we know that there is, in fact, a genetic component. Now, it's not one single gene that drives the development of Parkinson's disease, but there are different genetic factors, mostly less common, that can trigger or cause Parkinson's sometimes at an earlier onset than the average. The second thing we know about Parkinson's that's really changed our thinking is the importance of the cognitive dysfunction that can occur in people with Parkinson's disease. And 20 years ago, or certainly when I was in medical school, we didn't focus on this, but now we realize as our treatments for the motor component, the effects of Parkinson's on motor control, for example, can be better treated with medications, we're now facing what we call the non-motor or the cognitive dysfunction in people with Parkinson's.
And I know some patients have both Alzheimer's and Parkinson's together, which has to be incredibly complicated to try to manage.
Yeah, that's the other aspect of, as we think about an aging population, we're not only thinking about Alzheimer's disease and Parkinson's disease, but far more common is to see people who have mixed dementia. So there's a component of Alzheimer's, a component of Parkinson's, and probably a component of what we call vascular dementia, where cardiovascular risk factors, diabetes, high blood pressure, high cholesterol, smoking, all impact the blood vessels in the brain and lead to cognitive dysfunction, what we describe as a vascular dementia.
I know of individuals that have had memory disorders and specifically cognitive dysfunction that have had imaging done, and they find cerebral small vessel disease being evident in their brain, which is very scary to realize that our blood vessels are not as big as they were or as big as what we really do need them to be for good functioning. A lot of people mix up, I believe, dementia with Alzheimer. Can you talk about the number of individuals with dementia? I've oftentimes wondered if we went back, say, 20 years ago, were most people being told they had dementia and not Alzheimer because we didn't know enough to know better?
Again, going back 50 years, Alzheimer's disease, and if you define that strictly speaking by pathological criteria, meaning the pathological changes in the brain that one can see under the microscope, 50 years ago was a relatively rare condition. Why? Not because it didn't exist, but because people didn't live long enough to get to an age when they were vulnerable to develop the neuropathological features of Alzheimer's disease. And so when we think about Alzheimer's disease from a definitional standpoint, we need to be very, very specific. It's a particular pathological change in the brain, typically caused by the deposition or buildup of two types of proteins, amyloid and tau. The amyloid forms around brain cells. The tau forms inside brain cells. And while we don't exactly know which of those is the major culprit in driving the neurological dysfunction, they both together are, if you will, mechanistic triggers for the neurologic dysfunction. But if you look at people, say in their 80s and 90s dying, if we look at individuals who had the clinical features of dementia before death, only a relatively small proportion will have what we describe as pure Alzheimer's disease. A much larger proportion will have this mixed dementia, where there's perhaps some Alzheimer's, some vascular component, and some possibly other type of neurodegenerative process like Parkinson's disease or Lewy body dementia or frontotemporal dementia. So each of these probably has their own mechanism that we're going to have to learn about before we can actually get to an effective and definitive treatment. And we're making great strides in some of these areas, slower in others.
How about stroke?
So stroke is an enormous problem. In the United States, about 795,000 people suffer a stroke each year. Out of that number, about 600,000, it's the very first time. And in the remainder, it's a second stroke or a third stroke, or what we call a recurrent stroke. There's definitely areas of the country where stroke is a major problem. And if you look at the map of the U.S., the southeast is what we describe as being the stroke belt.
Why is that?
It's probably a combination of dietary factors, poor control of diabetes, and the epidemic of obesity and diabetes. And
So definitely lifestyle influenced, as well as more than likely some heredity, but the heredity really could be your dad was big and you're big and you both had diabetes and both had high blood pressure, et cetera, kind of on that risk road.
So again, I think the studies of stroke epidemiology have tried to unpack or decipher how much is a genetic component, and there clearly is a genetic component to stroke risk, and how much is related to potentially modifiable risk factors, like the ones you've just mentioned, diet, exercise or lack of, smoking, cessation, and diabetes. We know that by controlling those modifiable risk factors, not only does it reduce the risk of stroke, heart attack, but also of dementia. And so going back to our discussion of dementia, dementia is not necessarily an inevitable effect of aging. We now know if we can control some of these, we call them midlife risk factors, which are the same risk factors for stroke, we can potentially impact the subsequent later life risk of dementia.
I think one of the challenges is to inspire people to realize that they do have some control over their lifestyle behaviors and to exercise those good lifestyle behaviors early on rather than waiting until they're, say, 70 or 75. We want people to get in front of the train rather than that train already having left the station.
As a neurologist, I hear all the time, what can I do to prevent X? And X might be a stroke, X might be dementia, X might be ALS. Until recent years, the evidence that doing things like exercising, changing your diet, modifying those factors, the evidence has been relatively weak. But just in the last few years, there have been some very impactful studies. I'll tell you about one of them. One is called the Finger Study. This was done in Finland, and it combined what we call a multimodal approach to behavior modification. So there was a dietary component, a healthy diet, there was an exercise component, and there was a blood pressure component. And by improving those three factors in a large population of middle-aged subjects, they were able to actually improve cognitive dysfunction in a large proportion of subjects. And so we now have evidence that spending that time to exercise, spending that time to work on healthy diet can actually have an impact on cognitive function.
Many people in our audience listening to this podcast today are mothers who have children of a variety of ages. I think it's always good to begin very early on so that children learn that the norm for their diet would be a healthy diet rather than one high in fat and high in calories. Even more so, children and teens are not outside doing sports as they were when you and I were growing up, that they're inside using their thumbs and fingers on a little piece of technology that's entertaining them. We need to get them up off of the sofa and back outside again to play basketball and other sports.
I couldn't agree with you more. And I think locking in those lifetime patterns of regular exercise, whatever it is, and good eating habits at an early age, perhaps as early as early childhood, is critically important. We recognize now that 45% of Americans are classified as being obese, and that clearly begins in teen years.
Let's talk a little bit about new insights into motor control. Can you discuss that a bit?
So a lot of this really began with an initiative that President Obama began several years ago when he was president, with the BRAIN Initiative. It's a great acronym, and it stands for Innovation in Brain Research. And this was a $100 million investment by the government through the National Institutes of Health and the National Science Foundation to develop new tools, not to study a particular disease, but to understand how the brain worked. So to develop new tools, imaging tools, microscopic tools, physiological tools that can tell us how individual brain cells work. And so, again, the impetus of this was really to help us understand how the brain works, both in health and in disease, with the idea that eventually that knowledge would be translatable into discoveries for individual diseases like dementia, stroke, multiple sclerosis, ALS. And the BRAIN Initiative has spun off a number of really impactful, more basic science studies. And one of them that I wanted to talk about today was this concept that we've had in medicine, and certainly in neurology, for several hundred years, that one side of the brain controls the other side of the body. And so if you have damage to the left side of the brain, the right side of the body is impacted, and vice versa. And we now know from work that was published just last year that there is brain activation in both hemispheres, both halves of the brain, when there is damage. And so by recognizing that there is brain activity in both halves of the brain, one may be able to entrain or bring into action an undamaged part of the brain to help a damaged part of the brain work.
Clever. Wow.
So this is a new concept in motor control. And as we get closer to having the ability to implant electrodes into the brain that interact with our environment, with computers, with devices, with even cars and planes, we may be able to make use of this new knowledge that the motor control occurs in both sides of the brain, not simply in one half of the brain.
That's incredible. I'm just picturing where we may be 10 years, 20 years from now, with very different stories to tell, which would be fabulous.
Yeah, and I think one of the frustrating things is sometimes these basic science discoveries take a while to translate. And that really reflects the complexity of the brain. It's the most complex thing in the universe, literally. And taking a basic science discovery and moving that into something that can actually improve somebody's health or somebody's function, it takes a long time.
Yeah, that certainly is a frustration for the public, because they'll hear something on the news that there's been this discovery and they expect it to be available tomorrow morning at 10 a.m. if they call their doctor. It's just the beginning of what's going to be a long journey before something like that would be mainstreamed and available and part of standard of care, but it's awfully exciting. In looking at ALS, and our audience probably knows it better as Lou Gehrig's disease, Can you talk a little bit more about it as a diagnosis and what treatments there are currently available?
ALS, again, let's define the condition. ALS stands for amyotrophic lateral sclerosis. And like a lot of neurologic diseases, it's a mouthful to say.
So in case you're on Jeopardy tonight, you'll have that answer.
That's true. So Lou Gehrig obviously was a baseball player whose performance on the baseball field began to decline, and he was diagnosed at the Mayo Clinic with motor neuron disease. And subsequently it was renamed, I guess in his honor, as Lou Gehrig's disease. Motor neuron disease means that there is a slow degenerative process that affects the motor neuron. The motor neuron is the nerve cell in the spinal cord or in the brain that controls motor. So again, it goes back to our discussion we were having earlier about motor control. So motor nerves are critical for active movement. And so if I am thinking about moving my right thumb, nerve cells in my brain and in my spinal cord are activating to allow that movement to occur. If those motor nerve cells degenerate or die, obviously I'm unable to have a volitional or a voluntary movement, and I'm essentially weak or paralyzed. So ALS, as it progresses, tends to gradually involve more and more muscles. Unfortunately, we now know that it can also affect cognitive function in some people. This is a relatively new observation. But it typically spares aspects of neurological function like vision and, interestingly, bladder control. So it's a selective degeneration of motor control, and in some people can cause cognitive dysfunction.
Interesting.
So we've known about it for many years. The largest research center in the country is here at Johns Hopkins. It's called the Packard Center. It's headed by Jeff Rothstein with a number of other neurologists and neuroscientists who participate in both basic research and clinical trials and provide really extraordinary care for people living with ALS. There are about 3,000 deaths in the U.S. each year, so it's not a common disease. But if you talk to people around the country, almost everyone knows somebody with ALS.
Yes.
Or has had somebody in their family or a friend affected. The research has really focused in the last few years on a very specific aspect of nerve cell function. And the nerve cell is divided into essentially two components: the nucleus, which contains all of the genetic information for the cell, and the cytoplasm, which is the soupy mush around the nucleus. And in a healthy cell, there is a regular transport of material, particularly proteins, from inside the cytoplasm into the nucleus and then out. And Jeff Rothstein and his group here have identified that there are defects or dysfunction in this nuclear transport system. And we're just beginning to understand how this may relate to ALS. Again, it provides a new avenue for therapies. Currently, we only have 2 FDA-approved drugs. One of them was approved largely on the basis of Jeff Rothstein's work over 20 years ago. And the most recently approved came out 2 years ago. So we haven't introduced a lot of new drugs for ALS, and frankly, the drugs that we have a pretty modest effect. So we need a game changer, and our hope is that the research that's occurring here in the Packard Center will really unlock new therapeutic avenues.
That would be fabulous. How about multiple sclerosis? Where are we with that disease?
So MS, multiple sclerosis, is an inflammatory condition that affects the central nervous system. What I mean by that is the brain, the optic nerves, the nerves at the back of the eye, and the spinal cord. It doesn't affect other parts of the nervous system or the body. And it's another example of a selective disease like ALS. ALS affects the motor neurons, as I've mentioned. MS can affect different nerve cells. It can affect motor nerves. It can affect sensory nerves. It can affect thinking and balance. So it's a more protean disease in the sense that its manifestations can affect more systems than ALS.
How is it usually diagnosed?
So unlike ALS, which is typically has onset in the 50s, 60s, and 70s, MS is a disease of younger people. In fact, the average age is in their 20s. Women predominate. There's a ratio of about 3 women to every man who has MS. And there are very striking epidemiological characteristics of MS. It's much more common in people whose genetic background is from Northern European stock, if you will. So people who either come from or whose ancestors come from Northern Europe, Germany, Scandinavia, England, Scotland, Wales, etc. And we've puzzled about that for a long time, and we've now identified that there are specific genes. Again, not that one gene drives MS, but a collection of genes may influence the susceptibility to develop MS. So a genetic component is important, but also an environmental component. We know that people from Northern Europe, or whose ancestors are from Northern Europe, have lower levels of vitamin D. And it appears that lower levels of vitamin D cause the immune system to become overactive, to do bad things, and create an excessively inflammatory component within the brain and the spinal cord that may lead to MS.
That's incredible. I wouldn't think of vitamin D being related to that disorder. Tell us a bit more about MS from a treatment perspective.
Unlike ALS, where we've only had 2 FDA-approved treatments in the last 20 years, the story with MS is much more of a success story, I'm happy to say. And we now have over 13 FDA-approved treatments for MS that are what we call disease-modifying therapies. So they don't just treat symptoms, they actually treat the course of the disease. They can slow progression, meaning the getting worse that some patients might have if they were not on treatment, and they can reduce the number of attacks or relapses that patients might have. So these are really life-transforming treatments that we're now able to apply to people as soon as we recognize that they have MS, to begin treatments and to treat the disease in an aggressive form, in an aggressive manner, so that we can really get on top of it, to suppress the inflammatory response and to allow whatever natural repair and natural recovery can occur.
How about for Parkinson's from a treatment perspective? What is available? I think a lot of people picture Parkinson's as someone that's got the shakes, and that isn't the only thing that happens with patients who have Parkinson's disease.
That's a good description, and in fact, in the descriptions of Parkinson's disease by Dr. Parkinson in England in the 18th century, he called it the shaking palsy, meaning that there was an element of tremor or shaking, but there was also an element of impaired motor control. Parkinson's, as I've mentioned before, really combines both motor and non-motor elements. The motor elements are tremor, stiffness in the muscles, slowness of movement, a change in facial expression or lack of emotions on the facial expression, as well as the non-motor or the cognitive and behavioral changes. We've seen really amazing changes in how we're able to treat Parkinson's disease. We've known about the mechanisms of Parkinson's for 30 years plus. We know that this is a deficiency of a particular chemical transmitter called dopamine, and particular parts of the brain are deficient or have insufficient amounts of this chemical transmitter, dopamine. So by supplying the, if you will, forerunner of dopamine, which is called L-DOPA, in the form of a medication, we can increase brain levels of dopamine and restore some of the function that is lost in Parkinson's disease. So going back to a wonderful movie called Awakenings that Robin Williams participated in, which really told the story of how L-DOPA was introduced to people with Parkinson's disease of different types and how it transformed their life. Simply providing dopamine, just like we provide insulin to somebody with diabetes, can truly be life-transforming. I think what's changed from the point of view of medicines in the last 10 to 15 years is how we deliver the dopamine in long-acting forms, in forms into the intestinal tract directly, that allow for a much smoother dose response to the medication and limit the number of side effects that we unfortunately still sometimes see after many years of dopamine therapy. So we've gotten better at medicines. The other thing that has changed dramatically is our ability to control the tremor, which, as you've pointed out, is often stigmatizing.
Yeah.
And it's often the first thing that one notices with Parkinson's disease, this asymmetrical or one-sided tremor. So we're now able to control this in large part in patients using deep brain stimulation, putting a very fine filament-type wire into a specific part of the brain and using a pacemaker-type device to create an electrical impulse that shuts off the tremor. And for many patients, this is actually a remarkable
life-changing
success.
Restoring quality of life in a very significant way.
Now, the problem is that not everyone wants to have a wire put into their brain. It's an invasive procedure.
Sure.
Fortunately, doesn't usually have high morbidity, but we're now able to control tremor using a relatively non-invasive approach using focused ultrasound. Focused ultrasound means a very tightly controlled beam of ultrasound that creates a spot or a hole in a part of the brain that triggers the tremor. So without any cutting, without any holes in the skull, we can now essentially do what deep brain stimulation did, but using a focused ultrasound technique.
That's incredible. You spoke a few minutes ago about vitamin D, and I don't think that family practitioners and primary care physicians are routinely, when they do blood work annually for a wellness visit, taking a look at what a patient's vitamin D, specifically a vitamin D3 level is. Is this something that they should ask their doctor about when they're getting ready to get their routine annual blood work done?
Well, I'm asked this a lot by my patients who have MS, and they may have children because they're often, in their 20s and 30s, and they ask me, well, should my son or my daughter have, regular vitamin D blood tests? And we don't, frankly, have the answer to that yet, but I think it certainly makes sense. If you're a family member of somebody with MS, that means that you're at slightly increased risk of developing MS yourself. And if you know what your vitamin D is, and if it's low, you can correct it. That will lower the chance of you or a loved one getting MS.
Sounds like a very good idea. We've seen the same in the breast cancer arena. Individuals diagnosed with breast cancer oftentimes will have a low vitamin D3 below 30, and getting them on levels, first give them high dose for a while, prescription, and then keeping them maintained on a dosage by pill each day so that we can keep their level at 30 and above. We do encourage people to know what your vitamin D3 is, so that recognizing that's a risk factor also for breast cancer.
Well, I think the message is that vitamin D is not only important for bone health, it's important for immunological health. And this probably is true for diseases other than MS. Work that's been done here in the MS Center by Ellen Mowry, Dr. Mowry, found that if you can increase your vitamin D blood concentration above 50, it reduces the risk of an MS flare-up, if you have MS, by about a third.
That's significant.
So it's a very significant
Yes.
thing that we add to disease-modifying therapies as well as exercise and diet.
And we still want people to wear sunblock when they go out. We don't want them laying out there baking in the sun as their way of getting their vitamin D each day.
Yeah, it turns out it's not an efficient nor a safe way of increasing your vitamin D concentration.
Right. Yeah, for sure. Spinal muscular atrophy. Tell us about that. What have we learned?
So spinal muscular atrophy is, if you will, the early childhood form of ALS. Just like with ALS, it's a degeneration of the motor neurons. Other parts of the nervous system are not affected. It is a genetic disease where there's a specific gene defect in a protein that's critically important for the health and maintenance of muscles. So if that protein is deficient because of the gene defect, the muscles degenerate, and there's also motor neuron degeneration. What we've discovered in the last few years is that there are actually two copies of a gene that controls or produces this important protein for motor health. And by driving one of the genes that's still intact to produce more of that protein, one can potentially correct the whole genetic mechanism that underlies SMA. And that understanding, which came from basic science discoveries, really led to the first FDA-approved treatment for a neurogenetic or neurological genetic disease, SMA. And we're now able to treat infants and children, and in fact young adults who might have SMA with what we call an intrathecal, meaning an injection into the spinal column of a drug called an antisense oligonucleotide. It's another long word that means it's a small fragment of genetic material that blocks one of the genes and stimulates or turns on another gene to produce this critically important survival motor neuron protein. This has become available in the United States in the last 2 years, since 2017. And we're now using it, as I've said, in infants and children with SMA. It's an extremely expensive treatment. The first year of treatment is $750,000.
Wow.
Up to now, insurance companies or the company that makes the particular therapy have been covering the cost. And it is truly life-transforming. So for an infant who might have had another relative with SMA, by beginning treatment early, we can essentially allow that child to live a relatively normal life, developing normally, crawling, walking, climbing stairs, etc. Relatively normal motor development, relatively normal life, thanks to this life-transforming treatment.
That's incredible. We'll need to decipher a way to get the prices down at some point, because drug therapies for many different diseases and disorders are so expensive that if insurance or the industry that manufactures the drug doesn't cover it, that's something obviously that a family would not be able to afford out of pocket annually by any means.
I was in Congress a week ago with the Society for Neuroscience doing some advocacy on drug pricing policy. Certainly some of the members of Congress are very well aware of this, and bills are now moving through the House to try and fight this whole drug pricing issue at its root.
Yes. Talk a little bit about stroke and some of the advances in treatment, for example, gaming software.
So I'm so excited about some of the advancements in stroke. I mean, before we talk about gaming software, so in the last 3 to 4 years, so very recently, several controlled clinical trials have shown the benefits of what we call thrombectomy, which is clot retrieval. So a stroke often forms in the brain when a blood vessel is blocked or narrowed by a blood clot. And we've used blood dissolving medications, what we call thrombolytics, for about 20 years with, I would say, good but not great effect. Thrombectomy, which is the mechanical removal of the clot, not through a surgical procedure, but from inside the blood vessels, what we call an endovascular approach, which is similar to a coronary artery procedure, allows either an interventional neuroradiologist or a neurosurgeon or a neurologist who's trained to do this to remove the clot, just like you might remove a cork from a bottle of wine.
Okay.
And that allows the blood flow to be restored to the brain, and again, is absolutely revolutionizing how we treat stroke.
How quickly does it need to be done to so that the patient could have the best opportunity for a full recovery?
So as best we know now, within the first 16 to 24 hours, 24 hours seems to be the maximum time. And so early recognition of stroke, early recognition that there's a problem, either with weakness or language or other neurological function, and getting to a center that has both the capacity and the capabilities of doing thrombectomy. Unfortunately, there are large areas of the country that don't yet have access to thrombectomy within that time window.
Time period. Oh my.
So gaming software, it might seem counterintuitive to think that one could improve brain function with gaming software, the kind of thing that perhaps your son or daughter is using at home for entertainment. But it's been shown now that our standard or conventional forms of physical therapy and occupational therapy for stroke are usually delivered in, I'll use the medical term, in too low a dose. We're not doing enough. We're not doing it intensively enough to create the kind of recovery that we want to see in our patients. using gaming software that was developed by John Krakauer, Omar Ahmad, Pramit Roy here at Johns Hopkins in the Department of Neurology, they've essentially taken a game and turned it into an interactive platform to facilitate and encourage recovery. So what do I mean by that? Well, they're using a dolphin as the game, and an individual who, for example, might have a paralyzed hand or a paralyzed arm is able to use either a joystick or a robotic device to control the dolphin and to interact on the screen with the dolphin, putting the dolphin through different maneuvers. And as recovery occurs, so the game adjusts itself to become progressively more difficult. So it starts off easy, and then as recovery gets further along, so the game becomes more difficult. This is highly interactive. Even our older patients who might never have played a video game in their life find this very engaging. It's much better tolerated than, if you will, conventional physical therapy, which tends to be pretty traditional and difficult to get motivated for. This doesn't take away from the importance of physical therapy and occupational therapy, but it just gives us another tool to use very early after stroke. So after we've done the thrombectomy or treated the patient, removed the clot, we can now begin this aggressive rehabilitation strategy, both with conventional physical therapy and with this game-based recovery platform.
I have seen this thing in use, and it's marvelous. It also was wonderful that patients are enjoying it. I think it's a self-motivator. They know that they reached a certain level, and now they do want to go up to the next level. So that is absolutely wonderful.
So we're very pleased to say we recently received a very generous gift from United Arab Emirates to develop the Sheikh Khalifa Stroke Institute, both here and at the Cleveland Clinic in Abu Dhabi. And we'll be putting in place, both here at Johns Hopkins Hospital and at the Cleveland Clinic in Abu Dhabi, some of this gaming software to enhance recovery.
Excellent, excellent. Detecting technologies. You know, we're living in the world now of apps and various wearables. How are these helping in this particular neurology field?
The concept of biometric measurements, measuring, as you've said, heart rate, respirations, patterns of sleep, patterns of activity, are really the next big thing, I think, in medicine, because they really allow providers, whether they're physicians or advanced practice providers or nurses, to see what a patient is doing throughout the 24-hour time span, and not just for a 20-minute visit in the clinic or in the hospital room. Devices like the Apple Watch really allow us to do that in an affordable way. I mean, if you think about the Apple Watch, the fact that it contains the ability to measure movement with an accelerometer, to measure heart rate, to measure activity in different ways, is really phenomenal, bearing in mind, the relatively affordable cost of an Apple Watch. Just a recent study came out that relates to heart rhythm abnormalities detected on the Apple Watch, and showed that even the old versions of the Apple Watch, let alone the newer versions that have much more sophisticated electrocardiogram capabilities, are able to detect heart rhythm abnormalities that might lead to stroke or syncope, which is falling out or loss of consciousness. So we're able to use these devices. We have a project now in concert with Apple called the EpiWatch. And so we're using Apple Watches to detect seizures in people who have epilepsy, with the idea that we can not only track how frequently their seizures are occurring and adjust their medications, but the early detection of a seizure can alert a family member or a loved one that a seizure is happening, perhaps in the next room, so we can intervene at a much earlier stage.
That's wonderful. And does this also apply for a child, or today would it primarily be for adults?
So it certainly could be used for a child. Obviously, children, if you will, are one of the primary targets for developing primary epilepsy, which means a type of seizure disorder that occurs without any obvious structural abnormality in the brain. In the EpiWatch studies, most of them have been done in adults to date.
Something else I wanted to ask you about before we close. We've talked a lot about genetics and family history, I'm sure that there are many listeners who have been watching their television with all the various commercials about learning about your DNA and your ancestors. A little bit of information can, in fact, be a dangerous thing. Can we talk a little bit about how should someone go about finding out if they would be at higher risk because of family history or part of the country that their grandfather came from or some other genetic disorder? Because I always worry that people are using a little bit of information that they got by doing a buccal swab, getting some saliva from their mouth, and then they're trying to interpret reports that they receive in the mail. It might scare them to death rather than really benefit them. But what would be the best way to go about figuring out, are you at risk? How can I reduce my risk?
I think there certainly is a societal benefit to platforms like 23andMe, and there are other platforms out there. They provide a service. I think in general they're a good quality service, but one needs to take into account that they're only surveying a very small percentage of the entire genetic material that's in our bodies. So they're really looking for, if you will, the most common genes and gene defects. If one has a very strong family history, say, of a neurologic disease that's associated with a genetic defect, or a cancer, where there's a strong family history in a family of, for example, breast cancer or ovarian cancer, I would really recommend doing that in concert with a genetic counselor for two reasons. One, the genetic counselor can really guide one in the right direction in terms of what type of genetic testing to do, whether the 23andMe several $100 test is adequate or whether it needs to be a much more focused or sophisticated whole exome sequencing. And the second, doing it with a genetic counselor really allows one to have that interpretation of the genetic data once it becomes available.
I have recently learned that one of my best friends is soon to lose her father, and her father is very close to my age, which I consider not old. He was diagnosed with Alzheimer disease around the age of 58 to 60, and then Parkinson's a year after that, and he's now in hospice. One of the things that she is doing, and I've strongly encouraged her to do it, and she and her family have signed off on it, is that they'll be arranging upon his death, which will be very soon, to have his brain donated here so that it can be studied from a laboratory research perspective. I bring this up because I don't think that listeners out there realize the importance of participating in various clinical studies, including if the study means after death. I know how much we learned in the breast cancer field doing a rapid autopsy study and the really breakthrough treatments that resulted from that. And I'm hoping that this study that's going on at Hopkins now, for which this gentleman will be a contributor, and I see it as his legacy, will also discover a lot more about Alzheimer's disease as well as Parkinson's, with him dealing with both. Do you foresee in the future that we will continue to ask families or even the patient themselves if they want to have tissue harvest or are in agreement to have tissue harvested soon after they're gone? So I think that tissue is so incredibly valuable.
Well, first, I'm very sorry to hear about your friend's father, and it sounds like he, unfortunately, is dealing with a mixed dementia.
He is.
Which is, two hits and not only one. Rates of autopsy or post-mortem have dropped dramatically in the last 20 years, and I think partly that is on the part of society, feeling that post-mortem may no longer be necessary. We have great imaging, that we apply MRI scans and CT scans and biopsies during life, and so we often can make a definitive diagnosis, in many cases, before death, which obviously is the best way because we can potentially intervene.
Right.
But for some diseases, unfortunately, we don't have a treatment. We don't even have a name necessarily for that disease. And that's where an autopsy examination is really, in my view, critically important. It allows us to make a diagnosis, and often all the time I talk to patients with neurologic disease. We may not have a specific treatment, but they do want a name. They do want to know what Uncle Joe had.
Yes.
Whether or not there's a genetic component, they want to know why that neurologic disease occurred. I'm reminded very vividly of one of my patients with MS, who every time I see her, she reminds me that she has told me she wants to donate her brain after she dies, which hopefully will not be anytime soon. That's a wonderful example of how she wants to contribute to research, not only for her own condition, multiple sclerosis, but to help other people as well.
Yes, paying it forward for hundreds of thousands of people is an extraordinary legacy to leave.
Yeah. I think the advice that I would give to anyone who, whether or not they have a neurologic disease, if they're interested in helping with biomedical research, is to just have that conversation with your family. And I have had that with my own family. And certainly if I were to die, I would want my brain and the rest of me to be used for biomedical research to pay it forward, as you said.
Yes, wonderful. Thank you so much for joining us today. You are a wealth of information. I will subjectively say that I've had the privilege of watching you from a resident all the way up to becoming the chairman of the Department of Neurology, and I'm awfully proud of you. You're extraordinary. Thank you.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, your host, Lily Shockney, and a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. A Woman's Journey is grateful for the unrestricted educational grants from Biosense Webster and Boston Scientific that support our podcast series, Insights That Matter. For more information about A Woman's Journey, visit our website, hopkinsmedicine.org/A Woman's Journey, and like us on Facebook and Twitter. Until next time, stay well.